Arya join.
Hello, Federation of Clinical Pharmacists in India.
Good evening and welcome to the 10th presentation of basic modules in infectious disease organized by the Infectious Disease Forum of Federation of Clinical Pharmacists of India. Hi everyone, I'm Dr. Arya Kumar.
Am I audible?
Yes, you are. Please carry on.
Okay. Good evening and welcome to the 10th presentation of basic modules in infectious disease organized by the Infectious Disease Forum of the Federation of Clinical Pharmacists of India. Hi everyone, I'm Dr. Arya Kumar, ID Forum member of FCPA. I am moderating the session for today. Before we begin, I would like to give you some instructions. Firstly, if you have any questions throughout the webinar, please write them in the chat section. Your questions will be discussed during the Q&A session at the end. Secondly, the feedback forms will be available below the video thumbnail of the FCPA website towards the end of the session. Next, the certificates will be given within 10 days of submitting the feedback forms. The slides of the presentation can be downloaded from the website, and login is mandatory to download the file. And if you're facing any issues, we would like to hear from you. So feel free to contact us for any assistance through the email ID provided on the website. I hope the instructions are clear. Today's topic is antibiotics, pharmacokinetics and pharmacodynamics of antibiotics, part 1. And our speaker is Dr. Saidindu Ganda. He's an infectious disease clinical pharmacist from Hinduja Hospital, Mumbai. He's an ID Forum member of FCPA. He had 2 international pharmacy certification, SIDP, AMSP certificate, ASHP, pain management certificate. He has 4 publications and attended as a speaker for various national and international conferences. And he's currently a co-PA for ICMR project on antimicrobial stewardship program and research associate in other projects. And he also working in antifungal stewardship BCIDP panel. And his areas of interest are PKPD dosing of antibiotics, sepsis management, antibiotic log therapy, biofilm infections, and dose adjustment, medication therapy management. But before we start the session, I would like to give you about some information about the upcoming events. Join us to celebrate the first anniversary of the FCPA on World Pharmacist Day. FCPA, in collaboration with BPS, Board of Pharmacy Specialties, is organizing a virtual panel discussion on everything you need to know about BPS pharmacist certification on 25th September from 7 p.m. to 8 p.m. Indian Standard Time. You can just scan the QR code to attend the virtual event, and the registration is free. And the expert panels include Associate Executive Director of BPS, Brian Lawson, Ajmal, Anita and Sunny, Grace Mary John, and Muhammad Hisham. So all the queries that is related to BPS certification will be addressed during this panel discussion, and you can email your questions to FCPA mail ID, fcpaofficial@gmail.com. Second is the CP Conclave 2023 to be held on 15 to 16 November. It is organized by Amarda Institute of Pharmacy in collaboration with FCPA. The registration are on a first come, first serve basis. You can enroll now and secure your seat for the event. And the theme for CP Conclave 2023 is engaging students in infectious disease and antimicrobial stewardship. And you can submit your abstract on case reports, reviews, and original research for poster presentation. And you can also participate in a fun-filled ID quiz, and you can also take part in the antimicrobial stewardship themed cartoon drawing competition. You can don't miss this opportunity to interact, network, collaborate, and learn from the experts, and to prepare to spend. Also, be ready to prepare to spend 2 days of non-stopping learning from clinical pharmacists, physicians, microbiologists, and academicians. Okay, register soon because you don't want to miss any of the above possibilities if you attend this event. So you can download the brochure at FCPA LinkedIn account. Registration links are available in the brochure, and you can also submit your abstract at the link provided. Third is the CP Summit 2023, which is to be held in Pune and organized by the Indian Pharmaceutical Association Students Forum in collaboration with FCP on 25th and 26th of November. Fourth is the ID Congress 2024, which is to be held in ICRA Hospital, Calicut, in collaboration with FCPA from 19th to 21st January 2024. And the theme of the event is infectious disease and antimicrobial stewardship in critical care. So block your dates for the second ID Congress. There will be e-poster presentation. So be ready to present your research. The event needs live in-person registration, and follow our social media for all the updates. So without any overdue, over to you, Dr. Saidin.
Thank you, Arda, for introduction, and thank you to the FCPA for giving this opportunity. Yeah. Today I'm going to talk on antibiotic pharmacokinetics and in critically ill adult patients. And I don't have any disclosures. And the learning objectives of this presentation: explaining the principle that influence the pharmacokinetics and dynamics in critical ill patient, and describe the rational dosing regimens for antibiotics in critical ill patient. So what are the rational dosing regimens when you're treating critical ill patient? That is very, very important. And that pharmacist, rather than counseling, it always learn the PK/PD to optimize the patient outcomes. And so what is the basic kinetics definition when we learn in the intermediate in physics and chemistry? So basically, any movement, any object that can move in the medium in a open or closed, and where it is entered into the medium, how it is liberated from, and how it is absorbed, and where and how the object circulate in the medium, that is called distribution. And in how much medium the object is distributed, that is called the volume of distribution. In how much time it will stay in the medium, that is called half-life, or something stay in time. And how much it is moved in the medium, that is called distribution. And how it is processed in the medium, that is called metabolism. And how it is dissipated from the medium in excretion. In the pharmacokinetics, just we can apply to the drug, that it called as a pharmacokinetics. So that is the basic definition of kinetics. coming to the clinical pharmacokinetic definition, basically it is a quantitative description of in humans of behavior of the drugs with the different characteristics as well as the differences expected from the different route of drug administration. When you are giving the drug from the different routes, and what is the particular pharmacokinetics of the particular drug. This is we can study in the clinical pharmacokinetics. So the background, antibiotics are commonly prescribed in the critical ill patient. Early and appropriate antibiotic administration improve the clinical outcomes in especially in sepsis patient. All the guidelines recommending how to give early antibiotic, and but the problem is when you treating the critical ill patient compared to the other like who are the stable health patient, that pharmacokinetics of the drug is very different from the regular healthy adult patient. So you have to give the right drug and right dose and right frequency, right administration. Both all have the importance of administration to achieve the clinical cure and microbiological eradication. And the clinical pharmacist, the rationalized approach of the dosing is very, very important. Antibiotic PKPD issues in the critical ill patient. The regular dosing, if you see the standard dosing, suppose if you take the meropenem, generally regular dosing 5 mg TID to 1 gram Q6 hourly. But when you treat in the critical ill patient, these regular dosing based on the in vitro animal in vivo PK studies, and these doses rather than studying the human healthy volunteers, they don't consider the critical ill patient or special populations, and the same doses not suitable for the critical ill patient. And if you give the same dose in the critical ill patient, there is might chances of leading to suboptimal exposure, and it can lead to the therapeutic failure. Because when you're treating infection, the particular appropriate dose is exact dose is very, very important to treat the bug. So the critical ill patient will differ from the healthy adult patient. So basically, infectious diseases treatment is a puzzle with the different solutions. If you know the which drug is kill which organisms and where it is distributed in the body, and you can design any regimen to treat anything. So this is the famous quote from like professor is from USA, is a family professor in ID. And so what is the basic definition of pharmacokinetics? The time course of drug levels in the body fluids as a result of absorption, distribution, elimination after drug administration. So what are the basic characteristics? It can have absorption, distribution, metabolism, and excretion. So we are going to learn one by one. So what is the definition? Like percentage of absorption drugs dose that reaches the systemic circulation. So basically extravascular administration, we have a oral route. After giving oral administration or after extravascular administration, how much percentage of drug reaches the systemic circulation, that is called the absorption. But in case there are the couple of conditions where the oral absorption drug is altered, especially in the critical ill patient because of the particular altered pathophysiology and the pH of the stomach and the drug lipophilicity. Because of some particular oral antibiotics are not acid stable, those are acid unstable like penicillin G, and the drug lipophilicity, basically some antibiotics are hydrophilic antibiotics, they don't have much lipophilicity. So the drug should have a good hydrophilic and lipophilic activity. So if it is a drug is a lipophilicity, then it can absorb across intestinal epithelium is enhanced if it has a good lipophilicity activity. And if you see the oral route, when you choosing the oral route, please refer the biopharmaceutical classification system. It have a 4 classifications: class 1, class 2, class 3, class 4. This classification system describe the drug dissolution, drug solubility, and drug permeability. In which drug have a good solubility and good permeability, that we can consider as a oral route. So when you consider the oral route, you can consider that what are the important variables. What is the active transport of the particular oral medication? What is the facilitated diffusion, phagocytosis, and passive diffusion? Whether the diffusion depends on that ATP or non-ATP, and the solubility of the particular drug. So there are 2 things. One is the branded medication and another generic medications. So when you're in the generic medication, the dissolution, dispersion, disintegration, disaggregation, both are different from the branded and generic version. So you have to consider all these things when you're considering the oral medication. And the solid dosage form also, it inclines with the pH of the stomach and the GA transit of time and food. When you are giving with some particular antibiotics, that can affected by the food also, and GA bacteria. And after giving this solid dosage form, because of some dispersion, disintegration, that can convert into the solid particles as it makes a suspension. Then those suspension particles, they solubilized in that stomach medium or intestine medium or acidic medium or basic medium. So after that, there is a permeation through the membrane of the stomach wall or intestinal wall. They are directly going to the portal vein. That is have the systemic circulation that contains the blood. From there, they are going to the liver. But this permeation is affected by the two proteins. One is the glycoprotein and one is the cytochrome 3A4. So these are the important two enzymes affect the drug metabolism that can affect the systemic levels of the orally administered antibiotics. For example, the P-glycoprotein is one of the efflux pump mechanism in the intestine. So basically, that is it acts as a efflux pump. When your drug permeated from that into the systemic circulation, but these particular proteins from the systemic circulation, they efflux the drug to the again into the lumen of the stomach or lumen of the intestine. So basically, it acts as a protective mechanism. So when you have give you two drugs, if one drug act on the P-glycoprotein, if it increase the metabolism of that particular drug, that means because of the P-glycoprotein induction, because of P-glycoprotein, it can increase the metabolism of the particular drug. Then the particular drug is expelled from the systemic circulation. And the oral route, you can consider the stomach emptying time, food and poor circulation, GI dysfunction. So these are the some relative contraindications when you're giving the oral medications. Next, the sample question: 54-year-old male patient, known case of hypertension, diabetes, and regular medication. Hospitalized for the MRS uncomplicated bacteria, no infective endocardiac foci, and subsequent blood culture, no growth. Unknown source. The patient current is hemodynamically stable. For hypertension, is receiving the regular hypertensive medications. And current RX is injection of vancomycin 1 gram BD for 7 days. Plan for the discharge. The team wants oral options. The patient is technically eligible for the IV to oral. So these are the oral options: capsule clindamycin, tablet trimethoprim, and tablet linezolid, and capsule vancomycin. So what you choose in these conditions? How to choose the antibiotic? The basic answer is the linezolid. Then why we consider the linezolid? The first, when you considering that how to choose antibiotic, so you have to consider these couple of things. The find out the available oral options that already we have, and the check the particular bioavailability of the drug and the drug interactions, drug food interactions. So because through oral route we are giving sometimes with food. So sometimes there is drug food interactions also, and availability in particular in the formulary and cost of the medication, and the patient related concern and disease related concern. And if you give that particular drug, whether the patient, we need any specific lab parameters, is there any specific lab parameters required for that particular medications? So why we choose, if you choose the capsule clindamycin, not preferred. Maybe they don't have a role in the bacteremia, MRSA, but they have a role in MRSA, skin and soft infections. Tablet trimethoprim, if you see that options, it is inferior to vancomycin. There the risk of side effects because there are patients receiving already some couple of other medications that can cause hyperkalemia and hypoglycemia. Maybe these trimethoprim interact with these particular medications, and the tablet linezolid is a preferred, but the monitoring for the side effects. Linezolid have a role in the MRSA bacteremia, but is an uncomplicated. This is the recent evidences. And capsule vancomycin, it's only for the C. diff treatment, not for MRSA bacteremia treatment. So our option is the tablet linezolid. And there are the recent evidence shows IV oral route also equal efficacy as the IV route. If you these the couple of studies shows that oral route have a equal efficacy for as a IV route for especially some bacteremias. So these are the antibiotic with food interactions. If you give any antibiotic to the oral, so you have to, as a clinical pharmacist, whether your clinician mentioned or not, but that's your role to you have to educate the patient. If the patient is receiving doxycycline, you can counsel the patient, take the doxycycline with empty stomach with a full glass of water. If in case the patient taking the Bactrim with a full glass of water, chloroquinolones with an empty stomach. And these are the couple of counseling points you can consider when you're giving oral medications that can actually help to the patient. And so these are we around 18 antibiotics. What is the bioavailability of the this particular antibiotics, if you see the linezolid have a 100% bioavailability. That means after giving oral route, the percentage of drug available in the systemic circulation is 100%, means that oral dose almost 100% equal to the IV dose. So there is no point of you continuing the IV linezolid if the patient have orally eligible. So you can happily continue linezolid as an oral option, and levofloxacin, trimethoprim, doxy, clenda, cephalexin, moxifloxacin, amoxiclav, you can choose any of the antibiotic as an oral option if the patient is eligible for and as per the clinical criteria. And coming to the IV route. So why you consider the IV route in the clinical settings? Because we are expecting the rapid pharmacological action that depends on the Cmax of that particular drug. So the Cmax depends on the drug IV infusion, whether you're giving the faster infusion or slow infusion, how much dose you are giving, the volume of distribution, and the rates of elimination. So Cmax will be higher after IV bolus, basically because if you give faster IV bolus, there is a too short time for the drug distribution. So it will stay in the central compartment. It does not eliminate from the central compartment. That means if you give the faster infusion like IV bolus, the drug will stay in the systemic circulation only. So you can achieve early Cmax that can help actually. And Cmax will be if you give the longer infusion, you have to give some time to the drug to distribute and some time drug to the elimination. So you cannot achieve early Cmax if you give the longer infusion, particularly especially antibiotic loading dose with a shorter half-life like beta lactams. So what is the importance of loading dose? Why you consider loading dose? Basically, a steady state will take to at least 4 to 6 T of required to reach the steady state. But in a sepsis patient, we cannot wait for the 4 to 6 half-lives. Like some antibiotic have a 2-3 hours half-life. The 4 to 6 half-life means almost all it's around 10 to 12 hours. And a really sepsis patient, we don't wait for the 10 to 12 hours to reach the CSS. So that's why we give the loading dose to achieve the steady state as soon as possible. That is called the Cmax. And because of loading dose, we can achieve the early Cmax for some antibiotics, especially antibiotics with the smaller TF. And higher loading dose, there are some scenarios where a particular antibiotic of loading dose should be given slowly, especially drugs have a volume of distribution greater than the blood volume of distribution, because of when you give this drug directly, like they're distributed very fastly from the central compartment, means from the blood to the tissues. It's like it's happening in minutes or it's happening in seconds. The drug must stay, not much stay in the systemic circulation. So there is no point of like giving the regular dosing. You have to hit with the higher doses. Like echinocandins and the polymyxins, and these drugs you have to give longer infusions. You not give as a bolus, because there is a chance of redistribution. They can cause the toxicity, and that is one thing. And the impaired kidney function, liver function does not affect the loading dose. You always give the full loading dose. Doesn't matter if the patient come with the CLD, if the patient come with the kidney failure, whatever it is, but you have to give full loading doses. There are some couple of exceptions, but most of the antibiotic can give the loading dose. The Cmax always deal with the loading dose. CSS always deal with the maintenance dose. So if you see the formula, the loading dose depends on the volume of distribution. Loading dose directly proportional to the volume of distribution. So there is no relation. The loading dose not depends on the excretion of the drug. It depends on the volume of distribution. So there is no point of adjusting the dose of loading dose in organ dysfunction. And so in the critical ill patient, it can help to achieve the Cmax as soon as possible with the first dose only. If you don't give loading dose, or if there is any delay in the loading dose, if you give inappropriate loading dose, I mean, if you want to give if you give 500 mg rather than 1 gram, that is called the suboptimal loading dose, can change the pathogen susceptibility. So pathogen susceptibility changes occurs before the steady state. So even if you have initially you have a like pan susceptible bug, if you don't give the proper loading dose, if you give like lesser loading dose or the longer infusion, and that will change the pathogen susceptibility, the initial susceptible bug maybe later it converted as a resistant bug. So the loading dose, it helps to the Cmax, it can change the pathogen susceptibility also. For example, if you give the fluoroquinolones, if there is any like if you give the suboptimal loading dose of fluoroquinolones, that can cause the rapid induction of like ABC transporter proteins, especially in pneumonia population. There are some particular studies done in fluoroquinolones and S pneumonia. If you don't give proper dosing, within 6 hours, it can activate the resistant mechanism. And optimal loading dose minimize the and prevent the resistant mechanism. So that is important, like efflux pumps and porine express channel expression. So these are all can prevented by the loading dose. And what is the maintenance dose? The second dose usually we call maintenance dose. Some antibiotics have only one loading dose. Some antibiotics or some antifungals have two, three like ticoplanin, voriconazole, posaconazole, isavuconazole, like they have a multiple loading doses. So this maintenance dose, especially for it can maintain the sustained plasma concentration within the therapeutic range. So maintenance dose for maintaining the therapeutic concentration. So these maintenance dose should be administered at regular intervals to achieve the target, to maintain the target CSS. So, and these maintenance dose depends on the clearance. So if you see the maintenance dose formula, the dosing of depends on the clearance of that particular drug. So in these cases, you have to adjust the dose because the clearance may be liver clearance or renal clearance, but whatever clearance, the maintenance dose clearance, it depends on the clearance. So if you give the maintenance dose, the patient have a AKR or CKD or CLD, the maintenance dose only you have to adjust, not loading doses. So if you see this chart, and if we give the loading dose, the blue and gray line that shows the importance of loading dose to achieve the Cmax early. If you don't give loading dose, if you give the smaller frequent doses or continuous infusion without loading dose, it will take to some hours to reach the Cmax. I mean, some hours like maybe 10, 12 hours or maybe 20 to 30 hours. That is not acceptable. So we need to achieve the Cmax as soon as possible. That can only possible with the loading doses. And the distribution, we coming to the next distribution. Drug distribution from intracellular, especially from central compartment to the peripheral compartment, like extravascular fluid spaces. If you see the different compartments in the body, the total body water, it is a 60% of the lean body weight, and another one is the extracellular fluid. That is, it contains like interstitial and plasma. That is a 1/3 of total body weight. And if you see the intracellular, that is a 2/3 of total body weight. And if you see the plasma, the only that is 0.06 per kg. That means if your drug volume of distribution is less than 0.06 or 0.06, that means your drug stays in the only plasma only. Or if you are like volume of distribution more than 0.06, maybe the drug must not stay in the plasma. That means it can distribute to the peripheral compartments. So if you see that drug compartments, how the drug is distributed, before the distribution, you can see the physiological compartment. There is a zero drug in the physiological compartment before the drug administration because you are not giving the drug. The plasma is the 3 liter, extracellular space is the 14 liters, and total body water is the 42 liters. If you after giving the drug, the first drug distributed in the central compartment, that means blood, systemic circulation. So that means the drugs are distributed in the first in the plasma. What is the volume of plasma? That is the 3 liter. And after complete distribution of the drug, so what is the volume of distribution of the drug? That is the 42 liter. So all these things, basically the volume of distribution depends on plasma protein binding, tissue proteins, and absorption to the adipose tissue, and drug lipophilicity, hydrophilicity, and molecular weight. So these are all the factors affect the volume of distribution of the antibiotic. So depends on the relative solubility of the antibiotics. The volume of distribution, especially, it is altered during the critical illness organ dysfunction. So there is a fluid shift or third space phenomena called in sepsis. Because of capillary leakage, the displacement of fluid from the plasma, I mean systemic circulation to the interstitium. So because of this capillary leakage phenomena, whatever the drug stays in the plasma, they are directly going to the ECF, extracellular fluid. So if you give the regular doses, those are not stay in the plasma because of those are thrown out by the leaky capillary. So you have to give loading dose to maintain the Cmax. And the loading dose depends on the volume of distribution of the antibiotic. If the volume of distribution of antibiotic is very low, maybe it is equal to the plasma, that particular antibiotic stay in the plasma only. if an antibiotic volume of distribution more than the plasma, that particular antibiotic distribute around the body. So we'll show in the example. So if you see this chart, antibiotic volume of distribution in the critical ill patient. In the critical ill patient, volume of distribution of aminoglycoside, ceftriaxone, ceftriaxone almost all double. If you see the healthy volunteers versus the critical ill patient, ceftriaxone 10 in the healthy volunteers. The ceftriaxone means 20 liter. That means the 2 times the faster distribution of the ceftriaxone in the critical ill patient from the central compartment to the peripheral compartment. That means if you give the regular dose, doesn't work. You have to give high doses. So that is the importance of loading dose. And the hydrophilic antibiotics, you have to give the loading dose followed by the frequent maintenance dose with the infusion strategy to maintain the sufficient levels in the central compartment. And the lipophilic antibiotic, those are distributed in the intracellularly or into the adipose tissue. Basically, the lipophilic antibiotics not much affected by the fluid shifts. That's why you see that these all the antibiotics are the hydrophilic antibiotic. Itra, Vango, all the beta-lactam, aminoglycoside, those are the hydrophilic antibiotics. But in case of lipophilic antibiotics, these are not much affected by the fluid shifts because they already have a larger volume of distribution. So even sepsis physiology does not affect the volume of distribution of the particular antibiotic, lipophilic antibiotic volume of distribution. But when you're treating in a sepsis patient, you require higher dose to achieve the Cmax, the peak level. If you see that volume of distribution only limited the central compartment, if you give one drug that is 100 mg dose given, that means 100% of the drug in the 3 liter of the plasma volume. The plasma volume approximately the 3 liter. That means 100 mg in the 3 liter of the plasma. That means 33 mg per liter. So what is the volume of distribution of this particular drug? If you calculate the volume of distribution, that will comes under 3 liter. That means the volume of distribution of the drug is 3 liter, means that will stays in the only plasma because the volume of distribution equal to the plasma. And if you see that another chart like here, if you give 100 mg of the dose, then 1% of the drug if you stays in the 1% stays in the plasma, that means 1 mg per liter. That means 0.33 mg per liter. And the remaining 99 mg that distributed in the peripheral compartments are different tissues in the body. So if you calculated for this volume of distribution, that means 300 liter. See, the first one is the volume of distribution is 3 liter. That means the volume of distribution very low compared to the second one. The volume of distribution is 300 liter. If the drug have a higher volume of distribution, that means that does not stay in the systemic circulation, doesn't much stay in the central compartment, that always distribute into the peripheral compartment. If drug have a low volume of distribution that is equal to the plasma or less than plasma, that always stays in the systemic circulation only. That doesn't have distribute into the tissues. So even if you want to if you say see the volume of distribution of antibiotic in ICU, the drug which are stays in the extracellular fluid, those volume of distribution is 0.3 liter per kg, like aminoglycoside, penicillin, cephalosporins, carbapenems, daptomycin. So this is the one of the reason when the patient admitted the sepsis. Sepsis basically is a bloodstream infection. Basically, it is like plasma. So your antibiotic should stay in the systemic circulation. It should be stay in the ECF or in the plasma. If the drug have a high volume of distribution, doesn't much stay in the ECF. So that's why you don't consider the lipophilic antibiotic to treat the sepsis. So we can consider only aminoglycoside, penicillins, carbapenems, cephalosporins for treating this particular kind of sepsis. The drugs distributed in the total body water, clindamycin, linezolid, metro, vanco. So that is the reason we can treat using the clinda, linezolid for that SSTAs and CAPs and pneumonias and skin and soft infections, neck rash and everything. And the drugs high distribution to the tissues like colistin, fluoroquinolones, azithromycin, clarithromycin. Though this is the reason we can use macrolides for the intracellular infections like mycoplasma, legionella, atypical pneumonias. That is the reason the guideline recommending azithromycin, clarithromycin for intracellular infection, because they cannot stay much in the systemic circulation. They stay in the tissues only. They're basically called as an intracellular antibiotic, not extracellular antibiotic. So that is the reason we are using these antibiotics to treating some tissue-related infections. So there is sample question: 28 female with no significant past medical history, no history of UTI. came to the ER with a burning mixation, fever frequency and urgency. General condition is stable, conscious and coherent. The vital is stable and workup for the UTI. The send for the CBP and urine routine monitoring and blood culture and urine culture. Outside lab shows this has some little bit WBC elevation, CRP 25. Urine routine monitoring shows first cell 6 to 8, and the regular liver function, renal function is normal. ER physician ordered 5% tazobactam, 4.5 gram loading dose, followed by the 4.5 gram Q8 hourly. So the question is, this patient is required loading dose or not? So ideally, this patient not require any loading doses. So because this patient is not eligible for the loading doses, that clinically the patient is stable, and there is no volume of distribution, he is not in sepsis, there is no drain. So technically the patient is not eligible for the loading dose. We can discuss much later. So do not be the first to use the antibiotic because you risk the toxicity. Do not be the last to use an antibiotic because you risk the efficacy. So what are the factors increasing volume of distribution for hydrophilic antibiotics? When the patient have these couple of clinical condition, when you are using the hydrophilic antibiotics, you have to use the loading dose, like leaky capillaries edema, hypoalbuminemia, fluid therapy, because all these can cause fluid shift, like third space phenomena. All this can cause like movement of hydrophilic antibiotics from the central compartment to the peripheral compartments, from plasma to the ECS or outside of the plasma. So basically they tend to decreasing the regular dosing of antibiotics. So you have to give additional doses like loading doses, especially higher total body water condition like cirrhosis, CHF, pregnancy. So because these condition itself increase the drug volume of distribution, so they can increase the distribution of the drug into the peripheral compartment, and they tend to lower the plasma level. So you have to give loading dose or high doses. And what happened with the increasing loading dose, increasing volume of distribution? If the drug is in 1 liter, the concentration is very different. If the drug is in 1000 liter, the concentration of antibiotics is very different. That is called the dilution of the plasma. So to achieve the Cmax, you have to give additional dose. And if you see the beta-lactam volume of distribution ICU patient, the open circles is the healthy volunteers, and the field circles is the volume of distribution ICU patient. If you see that open circle is around 10, but in the critical patient, the volume of distribution is increasing. So that means compared to the healthy patient, the critical patient volume of distribution is drastically increasing. So antibiotic volume of distribution critical patient. If you see the volume of distribution, this is the like increase with the volume of distribution with the fluid shift S, and the decrease the Cmax with the fluid shift S. So that means you have to give high dose loading dose. And if you see the cephalosporins, they are also affected by fluid shifts, and the decrease in Cmax also affected by volume of distribution and glycoseptates. But except some antibiotic like tigecycline, this is not affected by the fluid shifts, and the Cmax also not affected by the fluid shift, and Cmax also not affected by. So because of the tigecycline have a higher volume of distribution. And we completed the distribution. We coming to the route of drug elimination. There are some augmented renal clearance, increase the clearance of particular antibiotic, hydrophilic antibiotics. We commonly seen in patient with traumatic brain injury and neutropenic sepsis, patient with engaged. Sometimes we can see they have a normal creatine, but they have a creatine clearance output around 130, 140 ml per minute. In that case, our kidney filtering the hydrophilic antibiotics very faster than the regular one. So there is complete washout from systemic circulation. So you have to give additional doses. And if the patient have any dysfunction, like renal dysfunction, that can decrease the clearance of the hydrophilic antibiotic, because the hydrophilic antibiotic excreted through the kidney only. If the patient have any transient EKI, that actually it's like a transient, it's not a temporary acute kidney injury. It not long stand for like it's not actually CKD. Maybe it may be 1-2 days. In that cases, it's not required to adjust the antibiotics because it's not actually true AKI. Maybe there are some other reasons for the AKI. In that particular conditions, don't adjust the antibiotics. You have to give full doses around 24 to 48 hours with the patient in shock. And increase the hepatic blood flow, enzyme induction, increase the clearance of the lipophilic antibiotics. So there are a couple of clinical situations. Sometimes you have to give high dose of lipophilic antibiotic because of this is the reason, because of increased blood flow and enzyme induction, increase the metabolism of these lipophilic antibiotic tend to decrease the total systemic concentration. So for lipophilic antibiotic also, this is the reason we are giving higher doses, initial higher dosing. And hepatic impairment, if the patient have both hepatic impairment and AKI, so that is also affecting the clearance of the lipophilic antibiotics. And reduction in the dose and frequency may require for depends on the pharmacodynamic of the antibiotic. What are the PK consideration with the reduced kidney function? Absorption is mostly unchanged, even with the patient have a reduced kidney function. And when you considering the oral dosage forms, you can see the gastroparesis. Sometimes patients with the diabetes, so you have to see that if the patient have a gastroparesis, that can affect the absorption of the antibiotic. Any bowel edema, any drug interactions, especially calcium tetracyclines with the fluoroquinolones, these are the maybe reduce the absorption of the antibiotic. And sometimes decrease in the first pass metabolism, maybe increase the bioavailability of the certain medications. And subcutaneous administration, significant subcutaneous edema may reduce the slow absorption. So, and IV administration is unaffected. And the PK consideration with the reduced kidney function. Distribution increase for the hydrophilic antibiotic compared to the lipophilic antibiotics. So because of that, if you're giving hydrophilic antibiotics in the reduced infection, you have to give the first dose should be increased because of increasing volume of distribution. And another point, hypoalbuminemia in the reduced kidney function. Because of albumin protein binding altered in kidney reduced kidney function patient, and that can the patient have a reduced kidney function, they have always have a like bluduria, elevated bluduria. These uremic toxins will change the protein binding of the antibiotic, that can increase the volume of distribution. So if the patient have a hypoalbuminemia, if the patient have so in this condition also you have to give first dose should be increases. You have to give high dose, first dose. So if you compare that healthy volunteer versus the patient with AKI receiving the RRT, the patient volume of distribution in patient receiving the renal replacement therapy, that is also significantly altered by because of RRT. So in these patients also you have to consider frequent dosings or higher doses or full doses. And PK consideration with the reduced kidney function, the protein binding is usually decreased because of hypoalbuminemia, altered protein binding, because of binding competition with other medications. We already discussed accumulated uremic toxins, increase the free fraction of the drug, increase the risk of ADRs. So higher loading dose should be with the first dose, but the maintained dose should be, you have to decrease. You can give the first full dose, but the maintained dose should be decreased because of the free fraction of the drug is increasing because of the reduced kidney function. Because reduced kidney function, the clearances depends on the renal dysfunction. So if you don't adjust the maintenance dose, there is a risk of side effects. When you consider the dose adjustment, even if the patient have a like kidney dysfunction, in which conditions you can consider dose adjustment, which condition you don't adjust the dose. If you see, there are a couple of conditions like if you want to give like a shorter duration of therapy for mild infection, you want to give fluconazole, you want to hit with the regular dosing 200 to 400 mg, no need to adjust the dose. And because we are giving a shorter duration of therapy, doesn't much cause any significant nephrotoxicity to the patient. So you can continue the full dose of fluconazole. And when you are trying Bactrim or triazole sulfamethoxazole for PJP prophylaxis, usually don't adjust the dose. You can continue the full dose even if the patient have a kidney dysfunction. And there are some situations I already told you, like transient AKI or reversible AKI, because that AKI due to the perfusion. These AKI is not actually the significant harm to the patient, and in that case, rather than adjust the dose, you can give the full doses, like hydrophilic antibiotic for sepsis. You can give the full doses for first 48 hours. And when you use it, adjust the dose. There are certain antibiotic can cause really severe side effects. Like if you take the beta lactam, the patient have accumulation associated with the ADR, like cepifime induced encephalopathy. If you feel patient have a new onset of like seizures or confusion or delirium, if you feel that because of drug, you can adjust the dose. So this is the adjustment criteria. The dose adjustment criteria if the narrow therapeutic index medication. If you give loading doses or first doses, even with the narrow therapeutic index like vancomycin, aminoglycosides, or colistin, or polymyxin B, if you give full load on this, you can give the full loading dose. Like colistin, give hit with the like 6 to 9 million units, polymyxin 15 lakh units, and vancomycin 25 to 30 mg per kg. Even with patient have a AKR kidney dysfunction. So because even they are narrow therapeutic index, but they are not eligible for the dose adjustment because the loading dose not depends on the clearance of the antibiotic. And adjustment criteria, there are certain antibiotics like aminoglycosides, vancomycin, and colistin. You can adjust the dose by therapeutic drug monitoring. Because these are the hydrophilic antibiotic, their excretion depends on their maintained dose depends on the clearance. That's why you have to adjust the dose. The protein binding without AK and CKD. Hypoalbuminemia increase the extracellular fluid volume. Hence, it can increase the volume of distribution by reducing the plasma oncotic pressure. It can increase the extracellular shift of the serum proteins. And hypoalbuminemia increase the serum drug concentration, but parallelly they have a increase the volume of distribution and clearance. So hypoalbuminemia without CKD, you can give higher loading dose, but it can increase the frequency of the maintenance dose. But if the patient have protein binding with AK and CKD, you can adjust the dose of the maintenance dose. If the patient have protein binding without AK and CKD, you have to increase the frequency. So that is the difference you have to understand. Sample question: history of UTI, no significant past medical history, ceftriaxone 1 month for E. coli, pan susceptible. Now admitted the sepsis, UTI, fibroid hepatitis, blood culture shows CRE E. coli with oxa-40 and NDM detected in BCID panel. Meropen and ticoplan and de-escalated because of blood culture goes CRE E. coli. So there is no role of continuing Mero and Tico. And we started Kazavi and Aztreonam, the regular standard dosing. But on the day 5, still patient have a fever spike, but vasopressor requirement stable, but little bit WBC are high. And the remaining things are normal. And the creatine clearance is 90 ml per minute. Serum creatinine is 1.1. And a patient have a low albumin. Basically, it's around less than 2 or 1.8 like that. So because of fever spike, the ICU team wants some clinical pharmacist opinion. What is the differential diagnosis? E. coli bacteria with UTI and the sepsis-induced hypoalbuminemia, and how to manage the antibiotic therapy in this case. So continue the same dose regimen of Kazav and Aztreonam and observe the patient. And because of patient have still 5% IWBC count, we can change to the polymyxins or adjust the dose of Aztreonam or consider antifungals. These are the like 4 options we have. Like what is the correct option in this particular case? So the answer is maybe he's still in and supports. He has a fever spikes and WBC count. Like it's like a case by case decision. Like we have options, but continue the same dose regimen. Watch and not ideal for this patient. Maybe mortality risk because in patient in still in sepsis in shock. And change to the polymyxin not preferred because that compared to the oxa-48 infection, polymyxins is like inferior. But the current data is very different. And adjust the dose of Aztreonam ideal because of the patient is hypoalbuminemia. And as we discussed, because Aztreonam is vectored by the protein binding, so we have to increase the frequency of the Aztreonam. Consider the antifungal. In this case, the patient don't have any significant risk factor for empirical therapy for antibiotics except ICU-TE. Then I think considering antibiotic also not a good idea for this patient. Just we can increase the dose of Aztreonam or increase the frequency of Aztreonam. That is a ideal choice. So it's not widely accepted practice, but it is a case by case decisions. When you have a patient, critically ill patient with sepsis with hypoalbuminemia, these are the particular antibiotics affected by the low albumin levels. So if the patient is not doing well and there is no other reasons to like explain the patient clinical worsening, then you can try these things like if the patient is receiving Aztreonam, ideally you can give the loading dose 2 gram Q8 hourly, and ideally the Aztreonam dosing is 2 gram TID. Generally we can in these situations we can give the additional dose like not TID, it will be giving the 4 times a day. Increase the frequency of administration. That is the recommendation. Like that is the like common, like that is not some kind of practice in the patient hypoalbuminia. The patient you are giving ceftriaxone. Generally, we are giving ceftriaxone 1 gram ODR, 2 gram ODR, 2 gram BD. But with the patient with critical ill hypoalbuminia, you can increase the frequency of administration. Itrapen, we are giving OD dosing, but in these cases, we are giving the BD dosing. Dapto, not much affected by the albumin binding levels. So we are giving like regular dosing or high doses. Ticoplanin, generally, we are giving OD dosing, generally 4 mg OD. But in this particular situation, we are giving the BD dosing, like 4 mg BD, if the patient have low albumin levels. Vancomycin, we can consider the continuous infusion, like our 3 gram OD continuous infusion or 1.5 BD. But in Indian settings, we are only prefer the ticoplanin. And glucagon, chlorhexidine, if you have the patient have a low albumin levels, you can give the continuous infusion. But we have a problem with sometimes, like especially Indian flucloxacillin, problem with like they always cause the tube blocking in hospitalized patient. And coming to the next, obesity, how obesity affecting antibiotic PK in. So volume of distribution for higher lipophilic antibiotics compared to the hydrophilic antibiotics. Consider dose adjustment for body weight, especially for loading dose to fill that volume of distribution. Hydrophilic antibiotics, as well as because they hydrophilic nature, they don't distribute into the adipose tissue. If dose based on the total body weight, because volume of distribution overestimation, that can lead to the toxicity. In these cases, you can use adjusted body weight for the loading doses rather than using the total body weight. Especially, example is the aminoglycosides. If you use the total body weight, it can cause the toxicity. So that's why for aminoglycoside obesity dosing, the recommendation is you can use the adjusted body weight. So that does not consider that adipose tissue mass, that adjusted body weight. Obesity, vancomycin, daptomycin, good penetration to the adipose tissue and no changes in the volume of distribution. So that's why that is the reason these two antibiotics have a good penetration compared to the aminoglycosides. Aminoglycoside doesn't have a good penetration to the adipose tissue. That's why we are using adjusted body weight. But for Vanco, Dapto, we are using the total body weight. Other antibiotics, you can use the maximum top end range and consider extended infusion of the prolonged infusions. And which body weight used for the colistin dosing in obesity patients? Like patient BMI is around 40. Total body weight or ideal body weight. So nephrotoxicity treated with total body weight dosing. So don't use total body weight. In total body weight based dosing, patient receiving additional doses may cause nephrotoxicity. In case of BMI is more than 31, ideal body weight is the recommended for the colistin. Because there is a complex PK parameters in obesity patient, not well studied. Increased age, diabetes, longer hospitalization prior to the receptor of colistin may be particularly at risk of nephrotoxicity. The duration of AK is the 5 days. So if the patient come with obesity, if you want to give colistin, so ideally prefer ideal body weight rather than the total body weight. One of the reason, these are the one of the reason, and the colistin also hydrophilic antibiotic with good volume of distribution. So you have to use ideal body weight. Next, burns. How the burns affecting the PK of antibiotic? You have to see the massive fluid restriction, increase the volume of distribution. So always higher doses to achieve the PD target. The burns decrease the myocardial contractility, obviously decrease the cardiac output and decrease the blood flow to the gut, liver. So they can decrease the hepatic blood flow, renal blood flow. That is and decrease the hepatic metabolism and the renal elimination. So less frequent dosing to avoid the ADS. Because of there is no metabolism, so the drug is slowly metabolized. There is no renal decrease in the renal elevation, so the drug is slowly renally eliminated. That means maybe you are expecting high drug levels, so you have to give less frequent dosing to avoid the adverse reactions when patient come with the burns. And oral route is not preferred if the patient is extensive burns that can affect the enteral absorption and maybe that delayed the onset of action. So always try to use IV route only. And this is in day 0 to day 03. And what happened in the day 4 to day 5. And post-burn hypermetabolic response, like 1 to 3 hours after the burn injury. And the changes in the glucocorticoid levels that can modulate the site metabolism of antibiotic metabolism, systemic inflammation, and oxidative stress, increase the myocardial contractility, cardiac output, blood flow. See, if you see the day 203, scenario is completely changing. And the day 2, day 4 by everything is increasing, blood flow to the gut, liver, and kidneys. So here you have to give higher doses. In the first 0 to 3, you have to give less frequent doses or lower doses to avoid the toxicity. But in the day 2, 4, 5, you have to give higher doses. This is very important for a clinical pharmacist. So you can observe that, see, in first 0 to 3 days, you have to give less frequent dosing to avoid the ADS because you have higher levels of the drug. But in the day 4, day 5, hepatic metabolism increase, your drug metabolism increasing, your renal elimination increasing. So in the day 4, day 5, give higher doses to avoid the therapeutic failure. Here also, you always prefer the IV route and don't prefer oral route because of faster enteral absorption, though shorten the onset of action. So if the patient born with, you are suspecting any infection, don't prefer oral route, and first 0 to 3 days, give the frequent dosing or less dose, and the day after day 4 or day 5, you can give the higher doses. This is the one of the common. This is one of the practice recommended dosing critically burn patient. The dosing of a little bit different. If you see piptas 6th hourly, generally we are using 8th hourly dosing. Ceftazidime, epiphem, that's okay. Imipenem, that's okay, but meropenem sometimes. Generally in sepsis we are using 1 gram TAD, except in neutropenic sepsis and meningitis, and burns patient we are using 2 gram TAD of meropenem dosing. Aztreonam 2 gram TAD as well. Other than we are giving 2 gram Q 6 hourly, and gentamicin you can consider the actual body weight, and tobramycin 10 mg per kg, and Cipro generally we are giving 4 mg BD or 4 mg TAD. Levoflox same dosing, but Vanco is we are using high doses, but not in India. But maybe these from the European and US countries, they are using very high doses. Linezolid, generally it is BID dosing in regular patient, but in the burns patient, we are giving extra high dose, extra 1 dose. Dapto, high dose 12 mg per kg, generally that is 7 mg per kg like that. And micafungin 100 mg. And if you have a any bug in the burn patient with MS is more than 2, and consider meropenem infusion over 3 hours. So representative PK properties of commonly administered antibiotics. Hydrophilic antibiotics, I already told you, they have a small volume of distribution. They stay in the plasma only, and they prefer to eliminate it through the renal route because of hydrophilic nature and the poor intracellular and tissue penetration. That's why we don't prefer to treat intracellular or tissue infections. And for examples like aminoglycosides, beta-lactam, colistin, dapto, fluconazole, pasco, and glycopeptides and lipoglycopeptides. The colistin is a little bit exception from the small volume of distribution. It have a good, excellent, high volume of distribution, and that is one of the reason we don't prefer colistin in bloodstream like MDR infections. And coming to the lipophilic, it have a large volume of distribution, so does mean it does not much stay in the central compartment. It always distributed in the tissues. That's why good for the treating tissue related infections or intracellular infections. Generally they tend to eliminate through the hepatic route. And example, fluconazole, lincosamide, macrolides, metro, oxy, oxidilodzones, posaconazole, tetracycline, and voriconazole. And there are some couple of exceptions. Cefazolin is a highly protein bound, ceftriaxone is a highly protein bound, etrapenem is a highly protein bound, and napcillin, axicillin, moxifloxacin. So we already discussed any patient with altered protein binding, we can consider dose adjustment of these antibiotics like cefazolin, ceftriaxone, etrapenem, and protein binding TF varies between the antibiotics. Then coming to the site-specific considerations, blood acts as a central compartment of the drug distribution. Sepsis alter the volume of distribution, increase the clearance of hydrophilic renally cleared antibiotics. Sepsis and ARC, consider that augment renal clearance dosing. The sepsis dosing is different, sepsis ARC dosing is different. So you have to keep in mind. And sepsis hypoalbumic dosing also different. In the sepsis have to be 3 phenomena: the regular sepsis, sepsis with ARC, sepsis with hypoalbumic. So you have in the rounds you have to see whether patient sepsis with ARC or sepsis with hypoalbumic. You can adjust your dosings. And sepsis with endocarditis, high bacterial inactive infections, choose antibiotic penetration to the vegetation. So any patient come with endocarditis picture with sepsis, like you can always generally in a sepsis patient with MRS risk factor, generally we can use meropenem and teicoplanin. But you have any reasons to suspect endocarditis, just don't use teicoplanin. You can start daptomycin because the daptomycin have a good penetration to the vegetation. So these very important things for the clinical pharmacist to suggest appropriate antibiotic. And the other reason we can consider dapto is as a biofilm activity. And we discuss the blood, and we discussing about the lung. High bacterial densities, the variable antibiotic penetration are the major barriers when you're treating the lung infections. But what are the points you can consider in choosing the lung infections? You can choose the extra ELF and plasma ratios for the extracellular pathogens. But intracellular pathogens, anyways, you are choosing the antibiotic with high tissue penetration, good penetration. But when you're treating the extracellular pathogens, you can see the ELF and plasma ratio. The antibiotics with good ELF and plasma ratio, linezolid and tigecycline, fluoroquines have a good ratio. That means you can consider these three antibiotics for treating lung infections because they have a higher volume of distribution and they have a lipophilic. They have they can penetrate into the into cells also. And the beta lactams, aminoglycosides, vancomycin, low ratio, less than 1, and they have a low volume of distribution, hydrophilic. So that's why we don't usually prefer these antibiotics treating the lung infections, especially aminoglycosides. So anyways, in the beta lactams, carbapenems have at least they have a 0.8 to 0.9 near to the 1 ELF plasma ratio. That's why we're using some like 4th generation, 3rd generation cephalosporins and carbapenems treating some LAT infections. And if you see the beta lactams, cephalosporins have a good ELF ratio and penicillin compared to the penicillins and carbapenems. So this is the ratio you can use for extracellular pathogens. And soft tissue infections, what you consider interstitial concentration of antibiotics for the extracellular pathogens. And data, it's very limited for soft tissue infections. We don't have much PK data. And antibiotic selections depends on the physicochemical properties and protein binding of the particular antibiotic, infected site, relative properties of the adverse tissue and muscle involvement. All these things you can consider when you're choosing soft tissue when you want to treat skin and soft tissue infections. And site bone. If you want to treat beta lactam bone infections with the beta lactam antibiotics, basically they have a hydrophilic nature and low volume of distribution, low concentration of the bone matrix. But don't consider, I don't say don't consider, but don't prefer it as a first line treatment for beta lactams or aminoglycosides for treating the bone related infections. In beta lactams, cefepime and ceftazidime and imipenem have a good bone penetration ratio compared to the other beta lactam antibiotics. When you want to choose like any beta lactam to treat bone infections, cefepime, ceftazidime, imipenem have good options. And other like even meropenem, it's like very good, very less penetration. Even with high doses also does not much achieve levels, so don't consider that. And the fluoroquinolones have excellent penetration, so they have a higher bone concentration compared to the serum. So you can choose fluoroquinolones as a drug of choice when you're treating the bone infections. Like coming to the CNS infections, degree of lipophilicity, presence of inflammation with the meninges as important CNS antibiotic penetration. And that means antibiotic with a good lipophilicity characteristics can penetrate the CNS well. Lipophilic antibiotic have a good CSF penetration regardless of the meninges inflammation. Fluoroquinolones achieve higher CSF plasma ratio due to the lipophilicity, diffusing the blood-brain barrier by the passive mechanism. The passive mechanism does not require any ATP, just it can glow like high concentration to the lower concentration. So that is one of the reasons we can prefer fluoroquinolones in the CNS infections. And if you want to give beta lactam, they need like some ATP dependent mechanisms to penetrate the CNS. Hydrophilic have penetration in the presence of active inflammation only, and the cerebral endothelial cells become more porous in the presence of active inflammation. So when you want to treat antibiotics, the meningitis, that is the reason when you hit with the hydrophilic antibiotics, there are like couple of recommendation for a certain like strep pneumonia and meningitis. The IDSA recommends like give the antibiotic before giving the steroids, because a steroid decrease the inflammation that might impair the penetration of hydrophilic antibiotic. But there are still some controversy on that. If you see the CSF ratio and plasma ratio, see one thing, your site concentration is always more than the plasma. So if the ratio is near to the 1 or more than 1 for that particular antibiotic, you can choose that antibiotic. But it's not always possible to we have a good ratio 1 or more than 1. So if you see the beta lactam CSF and plasma ratio 0.007, 0.25. That's why the beta lactams are not a good drug for treating CNS infections. And the vancomycin 0.15, immunoglykoside is 0.20. So there is another reason for we are giving high dose of meropenem to achieve the near CSF ratio, like 2 gram TID. And so because of these reasons, when you are treating some neurosurgical meningitis or post-surgical meningitis, we are trying to give intravenous administration of immunoglycosides like IT administration of vancomycin, polymyxin, colistin. So because these are the hydrophilic antibiotics, because of these are the we don't have good CSF plasma ratio, so we are considering alternative route like intraventricular route that can bypass the CSF. Some sample question: 61 years male patient, dialysis nurse, COPD, recent exposed to TB patient, history of cellulitis, wife have a MRS SSTI, admitted in ER, sweating and confusion, high grade fever, severe SOB, delirium, weight loss, cough 2-3 weeks, and SOVT 91% room air, decreased urine output. Start chest X-ray, dense lower lobe consolidation, HRCT cavitated necrotizing lobes, intubated in the ER, O2 support, nasal screening MRSA, shows MRSA, differential LRT pneumonia, TB, and AKI, because serum creatinine is 2 and creatinine is 38 ml per minute. So which is the appropriate antibiotic for MRSA coverage? Vancomycin, ticoplanin, linezolid in Indian context. So this is the case, and so basically they are suspecting like global pneumonia. So these are the options what you consider treating pneumonia in this particular patient. So because this patient is eligible for MRSA, so how to choose antibiotic? Assess the MRSA risk factors and prevalence of CAP in your area, and antibiotic site lung penetration, antibiotic dose, side effects, drug interaction. So this gives the complete picture of how to choose the antibiotics. The answer is ticoplanin. Then I'll tell you why we choose antibiotic ticoplanin. And the vancomycin is a moderate penetration, the primary recommendation, and patient already have AKI. So that is the one concern from the consultant. So that's why we don't choose vancomycin. And we have a better options like ticoplanin, because patient is sepsis and AKI. We don't know like how many days this AKI will there. So that's why we don't prefer vancomycin. Ticoplanin, good penetration, primary recommendation. But you have to keep in mind, we have to hit with the higher doses, 12 mg per kg OD dosing. Generally, we are giving 400 mg, but that Indian guidelines like recommending 12 mg per kg. Guidelines, not a consensus recommendations. You can see the references below. And the linezolid is a good penetration, alternate recommendation. But when you are treating in Indian settings, so the linezolid basically reserved for the TB and NTM infections. So now like we don't want to give linezolid. And the tigecycline is a good penetration, not preferred. It's not time to use the tigecycline because we have options. So, and moreover, it is a broad spectrum, so it's not option. So that is the reason we choose the ticoplanin. The ideal choice is the linezolid and ticoplanin. If you want use the linezolid, you have to use the 600 mg BD 5 doses. Then only you can achieve the proper AUC and proper lung concentrations. If you don't use the 500 mg BD 5 doses, you cannot achieve if you use the OD dosing. Same like ticoplanin also, if you use the high doses only, you can help to achieve the proper ELF concentrations. And if you see the tigecycline, vancomycin, those are not preferred because they don't achieve good ELF levels. They are not enough to kill the pathogen. The only linezolid and ticoplanin achieves. So as a clinical pharmacist, you have to know all these things when you are suggesting to the clinicians. So this is the way you can choose the antibiotics. And coming to the, I'm summarizing all the picture. If you want to treat the bloodstream infections, what happened with the antibiotic PKP pharmacokinetics? Increase the volume of distribution and enhance the clearance. That's why we are recommending the loading dose when you are followed by when you give the frequent dosing of beta-lactam antibiotics. Lung impaired the permeability. So try hit with the higher doses, always lung infections. And soft infections contingently on by the body composition, increase the dose in obesity. The bone impairment permeability, increase the dose, and you have to give it the higher duration, like longer duration of therapy. You cannot treat with the shorter duration therapy the bone infections. And the CNS also impaired permeability. So you can always, when you are treating the CNS infection, always with the maximal dose of the antibiotics. So these are the points when you are treating different site of infections, blood and lungs, soft tissue infections, bone infections, CNS infections. So these are the reasons, PK alterations. These are the reasons how to choose the antibiotics. So like just summary of the pharmacokinetic behavior of the hydrophilic antibiotics. If the patient have a critical illness, maybe that critical illness because of sepsis, the sepsis can increase the volume of distribution of hydrophilic antibiotics, then increase the loading of hydrophilic antibiotics. If the patient have any pleural, pericardial, peritoneal effusions, these effusions, surgical drains, and hypoalbuminemia, both are increase the volume of distribution of hydrophilic antibiotics. In sepsis, in effusions and drains, you have to give loading dose. Definitely, you have to give loading dose. Critical illness can cause hypoalbuminemia, that can increase the volume of distribution of hydrophilic antibiotics. You can give loading dose. And critical illness can cause hyperdynamic circulation, that can increase the renal clearance of hydrophilic antibiotic. That's why increase the maintenance dose of hydrophilic antibiotic. In hyperdynamic circulation, in case of hypoalbuminemia, in case of brain injury. That means overall there is ARC. The patient with critical ill with ARC composition, then you have to increase the dose of maintenance dose of hydrophilic antibiotic also. And critical illness with acute kidney injury, severe bone injury, acute leukemia, febrile neutropenia, febrile neutropenia, severe bone injury also increase the clearance of hydrophilic antibiotics. So you have to give high maintenance dose. That's why we are treating all neutropenic sepsis patient 2 gram TID whenever we required of meropenem, or like teicoplanin also we are giving with high doses. And critical illness with acute kidney injury, decrease the renal clearance of hydrophilic antibiotics, but AKI you have to decide whether it is a like transitional AKI, it is like a permanent AKI. Based on that, we can decide the antibiotic dosing. See, if the only serum creatinine is elevated, if the patient is urine output is good, there is blood urea is not elevated, urine output is good, and I think no need to adjust the dose. Like you can continue the full doses. Maybe it's not a true AKI. And loading doses, nothing to worry, you can give the full doses. But for the maintenance dose, you can decrease the maintenance dose of the hydrophilic antibiotics, or decrease the frequency. You can put the same frequency, but decrease the maintenance dose of the hydrophilic antibiotics. Suppose if you want to give meropenem less than 50 ml per minute recurrence, rather than giving 1 gram BD, you can give the 500 mg Q8 hourly. So for hydrophilic antibiotics, the frequency is very, very important. You have to give very frequent, maintain the, we can discuss in next chapter, like pharmacodynamics chapter. So you can keep the same frequency, like TID dosing for 1 gram TID, 500 mg also TID dosing. That is a TID dosing. You can keep the standard frequency, but we are decreasing the dose, 500 mg. From 1 gram to, we are coming to the 500 mg. That is the importance for hydrophilic antibiotic, even with in case of piptas also. So pharmacokinetics, I think we are only done halfway, and I'm low. So in next chapter, we are discussing pharmacodynamics.
Thank you, Dr. Saidulu. Your presentation was very informative, and we appreciate your expertise. So as we are running out of time for live questions and discussion, I want to assure you that your questions are very important to us. And if you have any questions related to today's presentation or any topic within this module, please send mail to our mail ID. So our I'm very excited to introduce our next topic of the basic module. Next topic is antibiotic pharmacokinetics and pharmacodynamics part 2, that is taken by Saidulu Ganda. So before concluding, I will just go through the upcoming events once more. FCPA is organizing a virtual panel discussion on everything you need to know about BPS pharmacist certification on 25th September from 7 p.m. to 8 p.m. Indian Standard Time in collaboration with Board of Pharmacy Specialties, BPS. Second is the CP Conclave 2023 organized by Amrita School of Pharmacy on 15th and 16th of November. CP Summit 2023 organized by the Indian Pharmaceutical Association Students Forum on 25th and 26th of November in Pune. ID Congress 2024 organized by ICRA Hospital, Calicut from 19th to 21st of January. So that is all for today's session. Thank you once again, Dr. Saidulu, for the presentation, and follow our social media platform for more updates. Thank you. Thank you, everyone.